the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Today's podcast, you got Chuck Dowell, Miles Gilbreath, and myself discussing what happens if you make a mistake. Miles and Chuck, what kind of other things have you had that have been problematic that left you thinking?
Going back to missed fractures, one, when we talked about doing this discussion, immediately came to mind. And this was about, I'd say 3 to 4 years ago. And I basically missed the first toe fracture that I ever saw. So I had a young kid come in between about 12 and 15, accompanied by his mother. He was at karate, and I think had kicked a heavy bag very hard, and kind of a weird, what seemed at the time to me, kind of an over-the-top presentation. The kid might not have been the most verbal, because I usually talk to my patient no matter what age they are, and the mom would always answer when I asked him questions. And so I kind of was like, hey, this is just a contusion. This is just a sprain. Let's put you in a boot. Let's have you, try and walk on it. And then, we'll have you see a foot and ankle team. And I have the same practice now to this day where I don't usually always close my charts that same night, but I come back the next day and I close my charts in the morning, and I review all of the x-rays once again from the night before. And I came to his x-ray and I was looking at it. And, for those that might not be quite familiar with a toe fracture, it's a pediatric fracture that involves the lateral tibial apophysis. And so it's kind of occluded there in that gutter of the ankle, as I call it. And, I looked at the x-ray and I was like, something just doesn't look right there. And so I contacted one of my foot and ankle docs, and he was like, oh yeah, it's a toe fracture, keep him off of it. And I was like, okay, crap. I didn't give that kid crutches. So I called the mom back, and like you said, Sam, anytime I make a mistake or need to change something, I'm very upfront with it. I tell them, hey, when reviewing this further, this is actually, he does have a fracture. He has a fracture of his growth plate, and it looks like it, it's going to be okay, but we need to keep him off of it. So, I need to bring you back in and I need to give you crutches. And I was apologetic for missing it the night before. And the mom was very understanding and appreciative that I called her and was following up on his care even after the visit. And so that's definitely a missed fracture that I'll never forget. And on those pediatric ankles, I never neglect to look at that lateral tibial growth plate, right? And so that's one that came to mind.
What's the other one with a toe fracture? There's another one at the pediatric growth plate. I think it happens medial.
There's a triplane fracture.
Triplane, yeah, that's right. Well, that might be it. It might be triplane, Volkman, something. But I think you're right. I did a podcast on this with my foot and ankle guy a while ago. But yeah, that's a hard one to catch, especially if you're new. That's an oddball one. What about you, Chuck? What have you missed that you would like to share?
Yeah, again, I think, we've all missed things. I as you both have said, I can distinctly remember multiple fractures, and obviously pediatric are kind of the big ones where, it's hard to interpret that growth plate when you're young in your career. And so like Miles said, I think one thing to advocate is to always go back to the x-rays, even after you see the patient, go back, after you've palpated where their tenderness is at, and look at the x-rays again. And I just, like Miles, sometimes will close my charts the next day and I'll go back and I'll see something subtle on the x-ray, maybe a small avulsion fracture or small growth plate irregularity, where I'll say, hey, maybe that is more significant of a fracture. And sometimes in a busy practice, that's hard to pick up when you're kind of trying to see 6 patients at one time. And I think the important key out of that is to communicate that to the patient. I think the patients are for the most part, very accommodating if you're honest with them. If you call them and you say, hey, I was re-reviewing your x-rays, I was re-reviewing your case, I was thinking about your case last night, as we all sometimes take these kind of complicated cases home. And I think maybe it'd be more significant than we think. And I'd like to get you earlier follow-up, or maybe have you come in and get more immobilization. I had a patient that had an Achilles tendon rupture. And it was more of that high kind of Achilles tendon rupture, right at that musculotendinous junction. And initially on presentation, I kind of palpated distally where the Achilles was at, and it was intact. But the mechanism kind of seemed to fit for more of this Achilles tendon rupture. And I put him in a boot with heel lifts like an Achilles strain. And I had him, do protected weight bearing. But upon reflecting that night, I was like, the mechanism fit for an Achilles rupture. It made me more concerned. And I talked to one of my foot and ankle colleagues about it. And he kind of mentioned maybe it was more of a muscular tenderness. We should probably get some imaging like an MRI. And so I called the patient back, similar to what Miles said. And I said, hey, I was thinking about your case. I'm concerned that this is more significant than we initially, interpreted after your clinical exam. And we got the MRI, and it did show it was a high complete tear, and he ended up getting it surgically fixed. And so I think the biggest thing from a take-home message perspective is when you're young, it's sometimes hard to admit your possible mistakes or to confront those because you're worried that, hey, I don't want to make any mistakes. But I think being honest with the supervising physician, calling and discussing it with colleagues, and then calling and being honest with the patients and saying, hey, I potentially missed this, but I want to make sure you get appropriate treatment. Those patients are always very happy that you called and that you were thinking about their case. And they're usually very accommodating to coming in and getting further testing and, or, immobilization or, different DMEs if necessary. So I think that's an important take-home factor.
I agree with that 100%. And well, let me ask you guys a question. Do you have overreads? I know, Chuck, you're full-time urgent care. Miles, yours is a little bit different. I'm not sure how much urgent care you do, but you guys get overreads with any urgent care stuff where, one of the surgeons looks at the x-rays from your night and kind of says yes or no. Do you guys have anything like that?
No,
I do not.
yeah. It's not standard practice. Anytime I have questions, I send the x-rays over to the surgeon. At the beginning of it, I would sometimes send spine radiology for overreads to a true radiologist at the hospital that we're contracted with. But it's not standard practice to have overreads, unfortunately.
Yeah, similar to Miles, I don't have overreads, but I have text numbers for all of the surgeons that I have at my practice. And so similar to him, if anything looks questionable, I always kind of send the x-ray to them, and it doesn't usually show up very well on your phone taking the picture. But we have a radiologist that is reading our MRIs in practice, and I can always kind of reach out to them and have them secondary look at it.
Yeah, that's a great resource. I mentioned that because I think our practice philosophy is, at least in my area, and I'm probably not going to get this right, but if you're less than a year into it or maybe 2 years into it, it's kind of a mandatory overread program where a surgeon looks at your x-rays the next day. Once you're past that, I don't think it applies anymore. Same thing you guys do, just send the x-rays if you need it. And the reason why I'm mentioning that is because it goes back to what Chuck was saying about contacting the patient and telling them. The overreads, when they instituted those in our practice, they were doing overreads on my patients, and somebody would have a question about something without looking at my note and have their MA call the patient without me knowing what was going on. And then I would get a message from the patient about, what in the world, you missed something or whatever. And it's like, that was a practice problem, I think. I don't think everybody was calling their patients, and that really gave me a problem. Let's put it that way, or made an issue for me, because I don't want anybody calling my patients before I've had a chance to talk to them. If you see something, let me know, let me call the patient, let me talk to them. You've got that relationship, somebody out of the blue calling. So I can see how that could be an issue for folks. And I know a lot of people out there get their films overread, people especially working in urgent care. So something to consider. Another thing that I wanted to bring up about a fracture with pediatrics, again, early in my career, I had a nice short arm cast on a buccal fracture, like a green stick fracture, whatever. Nice straight cast, no bend in the wrist, and on the lateral, it looked normal. And so I had the kid come back at, 4 weeks for a follow-up x-ray. I thought, it'd be fine, put you in a cast, it's good. They come back and the fracture's angulated about, 30 degrees or something, with callus forming. And I'm, at that point, oh God, what do I do now? So I asked my doc, same doc, well, don't worry, it'll be okay. It's going to take a few months, whatever. And I didn't believe them. I'm like, oh my God, I'm going to get sued. This is horrible. Career's over. So I had the kid come back like every week or two to get a follow-up x-ray for like 3 months. Didn't charge him office visits. I'm not like that, but get the x-rays. And over time, you can see it correct. So a lot of times things will take care of themselves, but it can be kind of harrowing when something like that happens. So I don't know if you guys have had anything like that.
Yeah, I mean, I think you can accept a lot of angulation and deformity depending on the age of the patient. So if they're younger patients, they have a lot of longitudinal growth through those bones. It's impressive of how much they can straighten those back out. And so I would agree. I've had patients with both bone forearm fractures that have 30 degrees of angulation. I'll contact my supervising physician and say, hey, what should I do? And they say, hey, just put in a cast, it'll be fine. And you're kind of like, well, how is that possibly going to straighten out? And a pediatric orthopedic doc I work with carries around a folder of x-rays of patients like this, where she'll show it to the parents and say, hey, look, this is at 1 week and this is at 3 months. And it's amazing how the bone will straighten back out over time. It is concerning, definitely, at first. And to mention on your overreads, I see that a lot with urgent care patients. Working in an orthopedic urgent care, I have a lot of patients that come in and say, hey, I went to the local urgent care and the x-rays were taken and they were read as negative. And then I got a call the next day saying the radiologist saw some possible subtle finding on the x-ray and recommended I come to see you guys at the orthopedic urgent care. And I have the benefit of a clinical exam. So I'll go in there and examine the patient and push on that area where that subtle finding was at. And the patient won't necessarily have any clinical tenderness in that area. So that's just a normal anatomical change that we can all see, whether it be like a secondary navicular or just a physis at the base of the fifth, and so, as you said, Sam, I think those overreads can happen, and it's difficult when you have a radiologist looking at an x-ray without the benefit of a clinical exam. So I think you all obviously have to touch the patients, have to examine the patients. We did that podcast on that posterior shoulder dislocation that I had. And that was, they went and saw 2 emergency rooms, and the emergency room physicians, I don't think, really examined the patient because he had no external rotation despite independent x-rays being read as negative. And I think us as providers have to be able to put that together, the x-ray interpretations and the examination together. And if it doesn't fit the picture, then we should seek somebody to look at them to make sure we're not missing something.
Stay tuned next week for the next part of our discussion about mistakes and what happens when they happen. Listeners, I hope you have taken advantage of our new membership drive. Please look at paos.org for details on how you can get some free CME before the end of the year.